everyone. Welcome to this webinar on COVID-19. It's a pleasure for me to moderate this session with three great radiologists from Europe, Dr. Russell Bull from United Kingdom, Dr. Monique Brink from Netherlands, and Professor Ernesto Di Cesare from Italy. I would also to thank Canon Medical System Europe for their help to organize this meeting, this webinar. The title of this webinar, as you have seen, it's CT for COVID-19 patient from emergency triaging to follow-up assessment. Then the first speaker is Dr. Russell Bull from United Kingdom, and he will do a good presentation about the modification, how COVID-19 has changed CT imaging in the United Kingdom. And the arrival of this endemic pathology and this waves after waves after waves has modified largely our interpretation and our use of imaging, and especially CT in COVID-19 and for other patients. The next speaker will be Dr. Monique Brink from Netherlands, and she will speak about CT in COVID-19 patient, her top 3 tips. And finally, we have Professor Ernesto Di Cesare from Italy. He will speak about the prognostic role of quantitative length CT in COVID-19 patients. We have a lot about intelligence artificial method, but we will know with Professor Di Cesare what is better and what we can have of what we can attend from this intelligence artificial for this. Now, the first presentation, we will start. I have the pleasure to present to you Dr. Russell Bull to present how COVID-19 has changed CT imaging in the United Kingdom. It's for you, Dr. Russell Bull.
Yes, thank you very much for that kind introduction. I'm going to talk about the experience we've had in the UK of COVID-19. I'm a consultant radiologist at the Royal Bournemouth Hospital in the UK, and I'm also a cardiac radiologist. And I'm also currently the president of the British Society of Cardiac Imaging, which is the cardiac CT organisation in the UK that covers both radiologists and cardiologists. Disclosures, I'm on the Speakers Bureau for Canon Medical. I'm doing that now, and the views that I'm expressing are very much mine, and they are not those of Canon Medical. So don't blame them. So Royal Bournemouth Hospital, it's a general hospital on the south coast of the UK. It's sadly not in the European Union anymore, but it's very close to the European Union. We're a general hospital, 900 beds, and we do pretty much everything apart from pediatrics. We have 3 CT scanners, 1 64 slice, and 2 wide area detectors. So we're a pretty representative hospital, we hope, for the UK. So the initial radiology response to COVID-19 was basically all but the most urgent outpatients were cancelled. The resources were very much directed to staff 2 inpatient scanners only, and a single outpatient scanner, which was physically separate, was kept for all urgent cancer scanning mainly. All cardiac CT and MRI, which I usually do, was suspended, and most outpatient CT and MRI was cancelled. And 50% of all the radiologists were sent home to home report, but then the system immediately crashed. Remote access server was fixed, and it was increased to 300 megabits a second from 10 megabits a second, so people could actually report from home. So the hospital went into full emergency mode, essentially. All elective cardiology was cancelled completely. All endoscopy, colonoscopy, bronchoscopy, anything that was aerosol generating was cancelled. All non-urgent surgery was cancelled, and all outpatient visits were gone. And the physicians were, and I've been physicians in the American sense, i.e. all doctors were redeployed to acute medicine and intensive care, so that we had surgeons on intensive care. Everyone was redeployed, just waiting. And we scanned a lot of COVID-19 cases in that first wave. So we have some very mild cases there, someone with a little bit of consolidation at the left base, some organizing pneumonia. And we scanned very severe cases as well. You can see someone there with widespread consolidation, young patient, lots of risk factors, left lower pulmonary embolus. Unfortunately, this patient did not survive. So what went well in the first wave of COVID? Well, some things kind of did go well. I mean, it wasn't all bad. Everyone in the hospital developed a real can-do attitude. People wanted to solve things rather than block things. So that was great. IT issues, which can be a big issue for us, and information governance issues were sorted out in minutes rather than days or years, which is what usually happens. Order comms, that was, the physicians had been blocking that for 5 years, and we eventually managed to implement it because we said we couldn't take paper requests anymore because of the risk of what we thought it was a risk of transmission at that point. 100% of all the x-rays were reported within 10 minutes. Everything was hot reported. All CTs were hot reported as soon as they were done within 30 minutes. And because we were keeping up with all the work, staff morale was excellent. And most patients, the other thing that was nice for us is we actually felt we were making a difference because most patients actually had something wrong with them. So what didn't go so well in the first wave? Well, outpatient clinical services completely stopped, and predictably, huge waits developed. And sadly, patients suspected of having cancer got outpatient CTs. So even those with some weight loss, but any other condition didn't get a CT scan. So if you were suspected as having coronary artery disease, you didn't get a CT, even though our incidence is also about 5%. So that was unfortunate. Patients with non-COVID severe illnesses just didn't come to the hospital at all. So we started seeing very late presentation myocardial infarcts, ruptured mitral valves, perforated appendices, things that I hadn't really ever seen before. And that was a very unfortunate effect because people were too scared to come to the hospital. And as this wave of cases really never came to our hospital because we were relatively protected on the South Coast, we had radiographers, radiologists, and acute medicine doctors standing around with actually not very much to do. We were underutilized. There was complete chaos with personal protective equipment. First of all, we were told we didn't need any at all. Then we were told that we did need it, but we didn't have any. And then we were said, now we have hardly any coronavirus and we have far too much of it. So that hasn't gone very well. So this is the first wave. There was a rapid peak, rapid fall. This is across the whole UK, the big spike and then a big fall. But the first wave only lasted a few weeks. So the actual spike was very short, but lots of processes changed. And a lot of these have been permanent, in fact. Much, much more use of CT as a first line test for all acute presentations. Much less thorough clinical examination happened partly due to PPE, people were wearing equipment, and it was, the perceived risk of transmission. So people weren't being examined. Less experienced clinicians were requesting CT, and they were requesting CT in areas that weren't theirs. We had surgeons requesting CT for the chest. This is perhaps not a good thing. Most routine outpatient visits were suspended, but CT was often used instead of those outpatient visits. It was used as a sort of virtual outpatient visit, particularly in oncology. We weren't kind of expecting that. So they were using the follow-up CT as the outpatient visit. And sadly, no extra resources were allocated to radiology or CT to cope with this. So pre-COVID, just an example, pre-COVID, transesophageal echo was used to exclude left atrial thrombus. But post-COVID, it was replaced with ultra-low dose wide area detector CT, which is total DLP of 16. So incredibly low dose. You can see the arterial phase there, the atrial appendages and filling. On the 20-second delayed image, the atrial appendage fills. So you can do a great examination at 0.2 millisievert without having to put a tube down the patient. Almost all colonoscopy moved to CT. Basically because people didn't want the invasive investigation anymore, and colonoscopy was a better alternative. And in the same vein, catheter angiography, which again requires patient contact, close patient contact, there was already a better test, which was cardiac CT. And now this just gave it the impetus for CT to actually replace it completely for diagnostic angiography, which has largely happened now across the UK. So what happened after the first wave? Well, there was a huge backlog of cases. There was reduced scanning throughput in most centres because we were wearing lots of equipment, we were doing lots of cleaning, social distancing, so throughput dropped, certainly initially. But CT remained this new first-line test for inpatients and outpatients. And outpatient clinics did not restart, but these virtual outpatient CT scans carried on. So we hope that COVID-19 was over in summer 2020 because the cases got really low, but everyone was warning us of a second wave, which in fact duly came. You can see there was a second wave that was as big as the first wave, and it was much broader. That happened in March time. So what happened during the second wave to CT services? Well, the second wave was at least as big as the first, but we all did cope much, much better with it the second time because we were ready for it the second time. All routine outpatient services continued as normal in radiology, assisted by local private hospitals. So we carried on, we did outpatient CT completely as normal, but non-radiology outpatient services all stayed shut. So radiology was the only thing that opened again, that everything else did shut. Basically well-fit outpatients were physically separated from inpatients and on separate scanners and were pre-screened for symptoms and required to wear masks. So we made sure they were low risk. Scanner cleaning became faster and more efficient. But actually, with the data now that shows you probably don't get COVID very much from hand transmission, maybe we didn't need to do that. Maybe that was a waste of time, but we did become faster at it. And the good thing was no radiology staff contracted COVID at work during all of the time, essentially, during that second wave. 2 radiology staff did contract COVID from their their sons from home who were in their early 20s, who were not distancing, I don't think, but not at work. So the incidence of coronavirus in the UK is now really low. It's going up and down in various European countries, but in the UK at the moment, it's low. And the adult UK population, as is the case in a lot of the rich world, is becoming fully vaccinated. In the UK, they'll be fully vaccinated with 2 doses by August 2021. So the question is, once we're all vaccinated, once the incidence stays very low, will we all go back to normal? Well, I don't think we will, for better or worse. Because even with the vaccinated population, the novel coronavirus will be here with us for a while yet, and invasive procedures such as colonoscopy, transesophageal echo, catheter angiography may never restart, as there are better CT alternatives. And for better or worse, the outpatient virtual clinics are here to stay. And these virtual clinics is a quick telephone conversation or a Zoom with the patient and a CT, or sometimes just a CT. But I think they're here to stay. That has changed. So should we try to turn back the tide? Should we try to stop this? Well, we did learn some hard lessons during COVID. Physical examination, history taking, and blood tests. We all love them, and we all went to medical school, but they often don't actually give you the answer. They often just delay the inevitable CT or MRI, which does make the diagnosis. It pains me as an ex-general physician saying that, but I think that's true. CT, I think, really is the physical examination of the 21st century, and it picks up a lot of things that physical examination cannot. Apart from the extremities and chest x-ray, we did discover, a rather hard lesson, that most plain films are a complete waste of time. So we've stopped doing a lot of them, particularly lumbar spines for trauma, cervical spines for trauma. They were never very good tests. Ultrasound, no, it's a great focus test. I'm not knocking ultrasound here, but it's an absolutely terrible general test just to see if there's anything wrong with someone. And we always knew that, but coronavirus made that even worse. We weren't going to put ourselves at risk of getting coronavirus for a test that wasn't going to detect the pathology when they could have a CT scan. So ultrasound, certainly for that indication, has sort of vanished, I think, correctly. CT is such a useful test that our job is to deliver it at very low radiation dose. And we've achieved this for the chest, but we're not quite there yet for the abdomen. So in the chest, we got low dose, abdomen, we're low dose, but not quite low enough yet. And during a pandemic, it's essential to separate low risk outpatients from high risk inpatients, separate scanners, separate waiting rooms. And the key bit is we need to divert funds from radiology to actually do all this. So despite the increases in CT scanning, patients are waiting longer. So this is a graph here. It shows towards the end of, despite all of our increase in CT scanning, patients are waiting longer and longer. So even though we've got more capacity, people are waiting a long time because CT is used so much more. So CT capacity in the UK is not very good at the moment. We're right at the bottom of the European League, and we need a lot more CT scanners per 10,000 or per 100,000 population to meet even the current demand, let alone the future demand. So does the scanning process need to change? Well, in addition to buying more CT scanners, which we clearly need to do, we need to scan, I think, much faster and much more efficiently. And the scanners need to be automated. They need to help us here so that scanning errors are minimized. So when you're wearing a whole bunch of PPE, you need the scanner to take over the heavy lifting. You need it to position the patient, put it in the middle, set the contrast dose, set the pump, set everything. And they also need to do it according to the protocol. So you can't set the wrong protocol. Radiation doses, you know, I want everything here, but they need to be even lower so that we can completely forget about radiation dose, even in the abdomen. I mean, the clinicians sadly already have forgotten about radiation dose, but we need to get it low enough that we can forget about it too. And ultra low radiation doses on CT scanners should be absolutely universal, shouldn't be a premium feature. And that's, you know, you shouldn't have to pay extra as a patient to get a low dose scan. So the UK government's answer to CT scanning capacity, which is in crisis, is community diagnostic hubs, so-called, where basically you can see the clinics and diagnostic services is a kind of tiny little outbuilding in there with the well-being support and the social worker and the midwife. So, you know, CT, I think it possibly needs to be a bit more than that. And see, I'm not sure it'll work in these community hubs. Maybe that's not the best thing. Maybe hospitals are better. But we all do agree, at least us and the government all agree, that the radiology workforce needs to increase. And there's thousands and thousands of more radiologists and radiographers are needed. And I'm sure that it's true in the rest of Europe as well. So in conclusion, the future of CT post-COVID, CT is a great test in the acute and outpatient settings, and its role has expanded still further during the pandemic. And the huge increases in CT scanning will be sustained, and I think will increase still further. We need to recruit more radiographers, more radiologists, and we need scanner automation to reduce the errors and to increase the throughput and to help us cope in those stressful environments. If radiation doses continue to reduce, we can use CT even more freely, and we can completely redesign patient pathways, putting CT at the beginning. So colonoscopy, endoscopy, catheter angiography, bronchoscopy, ultrasound, plain films, and even outpatient visits may never recover to pre-pandemic levels, and we need to divert the funds to radiology and to CT accordingly. And I thank you very much for your time to listen to us.
Thank you, Dr. Bull, for your presentation, clear presentation. And now we go to the next speaker, Dr. Monique Brink, for her presentation about CT in COVID-19 patient. My top 3 tips.
Thank you very much for the introduction. The goal of this presentation will be to discuss the value and the role of CT in COVID-19 pulmonary involvement. And I will do this by giving you my top 3 tips based on our experience in the last year in an academic medical center in the Netherlands, in Nijmegen. This is my disclaimer. And after that, I'm going to show you a CT scan, a representative slide of a CT scan of a 77-year-old female who presented to our emergency ward with typical dyspnea and fever, but a negative PCR for SARS-CoV-2. And I will show this slide here. And you can see this patient has some features which actually are typical for COVID-19. And in our center, we use a classification scheme to conclude that the presence of COVID-19 is still very likely despite the negative PCR based on a classification scheme. And this scheme we use is the CO-RADS system, the COVID-19 reporting and data system, which was introduced by the Dutch Society of Radiology in 2020. Which is not unique, as there are other classification schemes with the same goal, including the RSNA reporting system and the system of the British Society of Thoracic Imaging, which all give likelihoods of presence of COVID-19 based on imaging features alone, and they're all validated to the same extent. And are all used widely, not only in the Netherlands or in the USA, but also in other countries. If you want to know more about this system, resembling other RAD systems, I would advise you to watch the YouTube video of the Canon webinar in 2020, called COVID-19 Impact and Experiences. So the patient I showed you before had a CO-RADS 5, a very high level of suspicion with features typical of COVID-19. And in my talk, I will focus on the CO-RADS system, but my tips are not always, can also be used if you're not using the system as well. So whether or not you're using such a system, my first tip is look for features that are typical or just not typical for COVID-19. The so-called obligatory features, which are features you all know, they have to be present if you want to give the patient a high suspicion of COVID-19, including the peripheral, multifocal, bilateral ground glass opacities with or without consolidations. And it really helps if you have confirmatory features, and especially the thickened vessels are very interesting, I think, such as in this patient. You can see a thickened vessel in the ground glass opacity, which resembled an endothelitis. So an infiltration of inflammatory cells in the vessel wall and across the vessel wall with or without thrombi in the vessel. And this will decrease over time. So the vessel will decrease in size, but this might be one of the first confirmatory features. Other ones are the shape of the ground glass, such as in this patient, and grazy paving, which will appear a little bit later in the course of the disease, as you can see here, and which will disappear. This is the same patient, leaving you with less ground glass, but the reticulation is still present, and including some banding, and other features such as organizing pneumonia pattern. If you don't have typical or confirmatory features on CT, it's also helpful to look for features that help you to exclude COVID-19 in patients with suspicion of pneumonia. For instance, in this patient with central lobular nodules and tree and bud resembling bronchiolitis, which is not typical for COVID-19. The same holds true for segmental or lobular consolidations, which are not typical either. So my first tip is look for these features. The peripheral multifocal bilateral ground glass opacities, which are obligatory, and also the confirmatory patterns. And if they're not present, look for excluding features of other, which are more typical for other pneumonias. Then we go to the next patient, and this patient has a hematological history, who was immunocompromised and presented to emergency ward with dyspnea and fever and cough for 2 days. And as you can see, this is a CO-RADS 1 CT scan. So a CT scan with normal pulmonary parenchyma. However, after a few days, the patient got worse, had a positive PCR for SARS-CoV-2, and finally developed typical CT abnormalities resembling COVID-19. And this is an example of a false negative CT scan. And if we would have used CT in appropriate setting, we might have prevented this false negative CT, and I'm going to explain you why. That's my second tip. Use CT or CO-RADS in an appropriate setting. And what is an appropriate setting? Well, actually, if you would like to make a diagnosis, so whether or not a disease is present, you actually have 3 situations in COVID-19. The first one is a screening situation. You have a number of patients who are not symptomatic, but you want to exclude presence of asymptomatic COVID-19 in these patients. So you need a very sensitive test to select these red dots who are the patients here by preventing to get false positives. You have a triage situation, which means that you have a lot of patients with clinical suspicion of COVID-19, but you did not perform other tests yet. So CT is the first diagnostic tool you use in a diagnosis of the CT. You don't have PCR yet or otherwise, and you would like to roughly discriminate patients with a very high likelihood of disease from patients who don't have COVID-19. And you finally have the problem solver situation, which means that you use CT at the end of the diagnostic process, after you have done your PCR tests or other lab tests or physical examination, etc., and you are left with the complex patients, potentially the patients with a false negative PCR, such as in our first patient, or patients who actually have something else, but have a clinical problem which seems to be a little bit like COVID-19. And then you use CT as a problem solver tool. And if we look at validation of CT as a diagnostic tool, and especially CO-RADS and RSNA reporting system, we see that almost all of these systems have been validated not in a problem-solving situation, but in a triage situation. And what we see is that these systems, including the COVID system, actually perform really well. This was shown in a Dutch publication, a Japanese population, a multi-center Dutch population, and a Belgian population. As you can see, these areas under the curve are very high for patients with a positive PCR COVID-19 at the end, which means that this RAD system actually performs really, really homogeneously and really well. And this means that in a triage population, CT can add a lot of diagnostic additional information. However, the multicenter study of Schalenkamp also studied patients who had complaints of less than 48 hours. And what they saw is that, especially in these patients, the area under the curve dramatically decreases as low as 0.7, which means that in these patients, CT does not discriminate that well, as we saw in our patient before. So for this reason, we are not performing a CT scan anymore in patients who have complaints of less than 2 days. And finally, the SMET, the fourth study, also investigated patients in a screening population, so the asymptomatic patients. And what they saw is that the area under the curve also dramatically decreases if you are using CT in these patients, for instance, just before they have to undergo an operation or something like that. And for this reason, and several other studies have been showing that as well, CT does not have much value in diagnosing COVID-19 in a screening population. So what does this mean? In a triage population, CT works really well. In a screening population, it doesn't. However, using CT scanning as a triage tool is not the most cheap alternative. As we still have PCR available, we have enough material right now, it might make more sense to use the cheapest tests first. And if you're not getting to the solution, you might use CT as the problem solver. And that's how we use CT right now, only as a problem solver. And you can imagine that CT will perform less well as you're left with the most complex patients, but it might be that CT might discriminate still a little bit between different alternative diagnoses. So that's my top tip 2. Use CT and especially CO-RADS in an appropriate situation. Don't use it as in a screening, or don't use it in asymptomatic patients, even if you're asked to do that, for instance, on an oncological scan in which you find bilateral ground glass. Second, CT performs really well as a triage tool, but there are cheaper alternatives, and for this reason, we're not using CT anymore for that, and we only leave CT now as a problem solver, although we don't know yet on how good CT actually performs in this situation. And now we're going to the third and final patient. This is a patient who underwent a gastroesophageal operation and who had dyspnea and fever after that with a high clinical suspicion of COVID-19, as this patient was exposed to patients with COVID-19. And what we saw is bilateral ground glass on the CT, which was made with intravenous contrast, also to exclude post-operative complications. And this patient was given a CO-RADS 4 because there were some atypical features as well. But the patient never got a positive PCR or other signs of COVID-19 in the course of the disease. So this was a false positive CT. And that takes me to my final tip. Always check the differential diagnosis, because this was an ARDS, a normal ARDS in a post-operative patient. Check your pitfalls. For instance, mosaic attenuation in a patient who was scanned with intravenous contrast and hypoxic vasoconstriction and bronchopathy. This is not ground glass. This is mosaic attenuation. Check the important clinical relevant pitfalls, such as in this patient who has bilateral densities. They're more dense than ground glass alone, but these resemble pulmonary infarctions, which you should have missed, could have been missing if you would not have applied intravenous contrast in this patient. So be aware of that. Consider whether or not the patient can have pulmonary embolism. And the third pitfall is that a lot of patients with cardiogenic edema also develop pulmonary ground glass abnormalities, but also dyspnea. So be aware that this might be a differential diagnosis as well. In this patient, it might be easy with an enlarged cardiac silhouette and bilateral, more central ground glass abnormalities. But sometimes it might be more difficult, and you have to give the patient a CO-RADS 3 because you see bilateral, not very typical ground glass, and you just don't know. But take into account the cardiac history of the patient and look for features of cardiogenic edema in order to make that differential diagnosis. And of course, there are other differential diagnoses, more rare, such as alveolar hemorrhage, but also overlapping diseases such as influenza and PCP in immunocompromised patients. And it's not always very easy to make that differential diagnosis based on imaging alone. Other rare entities such as eosinophilic pneumonia, real organizing pneumonia, or pneumonitis, but it can be helpful to look at the history of the patient and previous CT scans and knowing whether or not the patient was on medication or radiation therapy. And finally, of course, interstitial lung diseases who can also give bilateral ground glass, including hypersensitivity pneumonitis and NSIP. And finally, and very rare, lymphoma or adenocarcinoma can, of course, also give bilateral ground glass. So that's my final tip. Check the differential diagnosis in all patients. You have some easy ones, you have some important pitfalls to exclude, but you also have problems or diseases with significant overlap in imaging features, and you have to be aware of that and take them into account. So these are my top 3 tips in COVID-19 CT. Look for the obligatory, confirmatory, and excluding patterns. Use CO-RADS or CT in an appropriate setting and check the differential diagnosis in all patients. Thank you very much for the attention.
Thank you, Monica Brick, for this good presentation about your tip. And now for auditors, if you want to ask questions, don't hesitate to set us by Q&R, and we will answer to all your questions. And now the last speaker is Professor Ernesto Di Cesare, who will speak about the prognostic role of quantitative lung CT in COVID-19 patients. And after this presentation, we will have some questions.
Okay, thank you. Good evening. Thank you very much. COVID-19 was named by the World Health Organization, or SARS-CoV-2 virus, as defined by the International Committee on Taxonomy of Virus, is responsible of severe illness in 14 of the patients. In 5 became critics with 49 mortality, and a diffuse alveolar damage has been observed during autopsies. As reported in this systematic review, many diagnostic models has been identified for detecting COVID-19, and in 75 of them were based on medical imaging, 10 for severity classification, and 107 model for predicting progression to severe disease. Nevertheless, the risk of bias was considered high, is represented in this picture in red, in most of the model, including prognostic models which suggest their predictive performance, probably only few papers were classified at low risk of bias, and in this picture is evident in green. In the recommendation on the use of chest imaging, the diagnosis and the management of COVID-19 published in this paper on Radiology February 2021, was reported CT appropriate as in patients with RT-PCR not available, in delayed results, in negative cases but with high clinical suspicion, or for assessment for hospital admission or home discharge, in patient selection for regular ward or ICU admission, and for therapeutic management, as was presented before. In more than 300 patients, as reported in this systematic review, chest CT provided a very high sensitivity, more than 90%, but low specificity, about 31%, and was considered useful in patients with some pre-existing pulmonary diseases. Purpose of our study was to evaluate the impact of quantitative lung CT in non-ICU COVID-19 patient prognostication. Our historical prospective study was composed by 55 patients from 72 to mean age was 72, 12 days as interquartile range, and the patient presented mild to severe respiratory failure in room air, no indication to mechanical ventilation, and CT submission with bilateral infiltration with a typical pattern of COVID-like. We collected an amnestic factor risk, symptoms, laboratory findings, respiratory findings, and quantitative CT findings. The primary outcome were admission outcome was outcome, and dead. The secondary outcome only dead. The method that we use an automatic quantitative lung CT software on Vidrea advanced visualization that provide an accurate detection of lung volume, differentiation between different aerated areas, identification of lung and different areas weight. And the data were obtained by a CT Canon Aquilon 1, 320 detector, raw detector, and 0.5 millimeter collimation. We were able to differentiate the non-aerated areas plus 100, minus 100 Asfield unit that were referred to consolidation or atelectasia, because we were unable to differentiate between alveolar filling and the collapse of pulmonic parenchyma, and poorly aerated areas that we considered between minus 100, minus 500 Asfield unit that were referred to ground glass opacities, and normally aerated areas between minus 100, minus 950 Asfield unit, and finally overinflated that were referred to the emphysema minus 950 unit. With this software, we were able to analyze in a very accurate way the lung volume. We were useful to evaluate high density areas, and especially we obtain a differentiation between different patterns. And in this example, you can distinguish between ground glass that is evident in yellow, and consolidation that you can differentiate in blue color. But also, this is the particular aspect that I want to stress from our research is that we analyzed the lung weight as lung volume and mean density plus 1,000 over 1,000 that was able to provide a calculation of different arrayed areas through volumes and mean density. And in this way, we obtained an estimation of lung lobe weight by a semi-automatic CT analysis. Our the results are quite interesting because we divided patients that were discharged and the patient with worse outcome. And if you look the differences, you can analyze that between the clinical risk factor in our series, the obesity showed great differences between the groups, and between symptoms of the dyspnea was the most significant aspect in the distinction of these two different groups, but also the fever and hypertension and diabetes and COPD were significant in these two groups. Analyzing the respiratory and the laboratory findings, we can observe a great significance between the same two groups, discharge and the worst outcome for the neutrophil lymphocyte ratio, LDH, D-dimer, as you can see, but also if you look at the respiratory data, VO2, SpO2, and PF ratio. Finally, we analyzed the data from CT, and you can see that differences were evident with good significant p-value for total lung volume, total non-aerated lung weight, probably better, and also totally poor aerated lung weight and totally normally aerated lung weight. But when we calculate the percentage, you can look at a great increase in the significances between these two groups. If you look both non-aerated lung weight percentage, you can observe a p-value of 0.001, and similar data you can observe also for non-aerated lung volume percentage, high density lung weight percentage, and high density lung volume percentage. In these 55 patients, you can observe that 45 patients were discharged, 8%, and 20% had the worst outcome. And if you look at this Cox regression analysis, the significance in the univariate analysis was evident in most of the parameters, but the multivariate analysis showed significant differences in total non-aerated lung weight, in non-aerated lung weight percentage, and in high density lung weight percentage, providing an independent predictive value. Finally, if you look at patients with low percentage of non-aerated lung weight and high percentage non-aerated lung weight, you can observe for both primary and secondary outcome great differences. And this is particular of the interest because if you analyze different model, if you analyze only clinical element, this index is in our group 80%. If you analyze clinical data and respiratory laboratory data, this index increased to 94%. And if you introduce also the volume of the lung, the percentage of lung volume, there is no increase in the value of this index, but if you add the weight of non-array de Lang, you can look an increase of this index to 97%. And this is our best result. So we can conclude from our experience that COVID-19 need an accurate stratification for adequate workup. Quantitative lung CT offers significant insight into lung disease and seems really interesting that quantification of non-aerated lung weight increases the prognostication of COVID-19 patients. Thank you very much.
Thank you, Professor De Cesaro, for this presentation, clear presentation. May we start our question and answer? Then first question is for Dr. Brink. How to differentiate acute ground glass opacities from residual one without fibrosis in patients without fibrosis?
Thank you very much for the question. Well, the easiest thing, I think, of course, is to look at previous imaging, but I don't think that that's the answer the person who asked the question was looking for. But there are other signs you can look to. If you see ground glass and you suspect it to be a feature of COVID-19, you can look to other changes that evolve over time in COVID-19. So as I showed you before, for instance, the thickened vessels and the endothelitis are present in the beginning and in the active phase of the disease. And in a few weeks or days later, the diameter of the vessel starts to decrease. So that's something you can look at. And of course, other signs of involution, such as parenchymal bands or lines close to the pleura or in the region where the ground glass or the inflammation had been active before. So these are signs that can suggest that well, the ground glass has already been there for a while. And maybe you have read the article of Bernheim, which was published in the early stage of the COVID-19 disease, in which several stages of COVID-19 have been published. But what we saw is that actually in one lung, multiple stages are present. So it's a very highly, well, it has different tempi of disease in one lung. So there is active ground glass, but there is also some kind of fibrotic things, of course, crazy paving happening, and inflammation is jumping from one region to another. So that's what we also see in COVID-19. So it that can help you. And if you're questioning whether or not that this ground glass might be something from, well, like an adenocarcinoma or something like that, that might sometimes be pretty, yeah, not very easy. And sometimes your clinical data can help you. Does this answer the question? Maybe other panelists can add something to that.
No, in fact, if you have patients with a suspicion of COVID-19, the presence of ground glass opacity is very suspicious. Yeah. And then the question is, in another situation when you don't suspect this, and you found ground glass opacities, and in this situation, did you say that patient has COVID-19 or not? And in this case, we have to look at other signs. What did you say, like the thickening of the pulmonary artery or bilateral and other signs associated to this?
Yes, exactly. Yes, thank you.
Okay. One question also, what is your criteria for identifying a thickening of the pulmonary artery? For Dr. Brink.
Yeah, that's also a nice question. Of course, you can look at the bronchus in the region, but this can also be can have a pathological diameter. So it is actually a vessel should taper to the periphery, and if it doesn't, it's highly probable that it's dilated. So you actually have to look to dilation of the vessels in the periphery. I hope that helps.
Because I find it very difficult for me to see the dilatation of the pulmonary arteries.
Yeah, exactly. In my example, because I'd only showed you the dilated vessel and not the other ones. So it is also a relative, yeah, you have to look at it relatively. But if you see it, it's really helpful.
Okay, thank you, Dr. Rick, for your answer. And now for Dr. Bull, regarding the follow-up of hospitalized patients with COVID, what is the percentage of CT scan done with IV contrast, especially to detect pulmonary embolism? And what are the criteria to perform angiocytogram, CT scan to diagnose the pulmonary artery in patient in emergency situation?
So is that to be, Prof?
Yes, it's a hard question.
Yeah. Well, I can tell you what we do. If we're following up symptomatic patients post-COVID, we do a CTPA protocol in all of them, including subtraction. That's what we do, because but we have a lot of, most of the studies, again, it depends on your prevalence. We were talking about this before, but these people have had COVID, they've recovered on chest x-ray, and we're doing a CTPA because they're still breathless. And they're usually normal, these studies, but clearly the patient's breathless. So I think we're missing something. But you know, we do everything we can. We always give contrast if we're following up for COVID, but we could be atypical because we're a fairly low prevalence area. So what we're following up is we're not usually looking for lots of lung fibrosis. We're looking for persistently breathless people with a normal chest x-ray. So maybe our cohort's slightly different than places where they have a lot of lung fibrosis. Maybe Monique's cohort is slightly different from ours.
Okay, thank you for this answer. In France, in fact, we have a huge problem with our emergency physicians, because they asked us a lot of CT scan, angio-CT scan, to exclude pulmonary embolism. And we have to do some criteria before accept this. And we have to choose we could be discussed that a very high DDMR, more than 3,000. And in the emergency situation, not patient come to the hospital, not patient in hospitalized situation, coming to the emergency department. And for a patient hospitalized, it's only with the worsening of the symptom without modification of CT scan. In this case, we administrate iodine to do a pulmonary angio-CT scan. Dr. Brink, is this something?
Yeah, it's the same. Yeah, we prefer the patients are followed with D-dimers, and if there's a jump in the D-dimer and it has to be pretty high in thousands, then we perform a CTA. So our CTAs have been almost doubled the last year because of COVID-19, and very frequently it's nothing. In the first wave, about, I thought 10 to 20% was positive, and now it's less. So it's kind of an overshoot, I think, what we're doing right now, but that's something we can treat. And so the jumps in D-dimers in our center are the reason to perform a CTA. And of course, patients with a high pre-probability of pulmonary embolism, just like before COVID-19, are getting a CTA pulmonary embolism, and we use the years criteria for that.
Okay, thank you. For Dr. De Cesare, do you use percentage lung involvement in your final radiological report?
Yes, really just in the last time we decided to introduce this aspect, and this was obtained, of course, from our experience that we performed with my previous experience that I reported, and we consider that there will be particularly useful in the follow-up of the patient to evaluate the evolution of the disease, because we consider to reevaluate this patient at 3 months, and we don't know what will be the evolution of the extension of the disease. There is also another question I see in the chat. Because there is I don't know which one, that asked me if the algorithm is adequate to distinguish vessels from lung and the consolidation. My experience is quite good from this software because, of course, in the normal lung, the distinction is easy and completely automatic, and it works quite well also in the ground glass, but some difficulty, of course, can be present into the consolidated areas, but for small areas, this can be reduced because we can interact with the software in way to obtain the maximum distinction between a vessel and the consolidated area.
Okay, thank you. May I have one question about this? How do you use it to differentiate condensation from chest wall? Do you have some difficulties? Because I
no, really. With chest wall, the software work very well, and generally we don't have any problem.
Okay. In what cases do you do control CT?
Sorry, I'm on mute.
Okay, I will answer. In fact, control CT scan for patients with COVID-19. Do you do a control CT scan? In fact, in our experience, we do this if at 1 month follow-up, but if he has persistent of symptom. If patient is asymptomatic, we don't do a control CT scan. If he is symptomatic, we do pulmonary function and chest CT scan. And according to the results of both, we can go further follow-up. If CT scan is normal, we stop CT scan and we continue the follow-up by pulmonary function. Or if CT scan is abnormal and pulmonary function are abnormal, we follow by pulmonary function at 3 months, and it has a revolution or decreasing of the capacity of the pulmonary function. In this case, we perform CT scan to do not irradiate for irradiation, even if it's a small quantity of irradiation, but it's some irradiation. And then we prefer to do pulmonary function than CT scan as follow-up. And we perform only CT scan if we have a worsening of the results of pulmonary function. Yeah. Do you have the same idea of this follow-up?
Yeah, well, the truth of it is we do very little follow-up CT of COVID patients. It's partly because we have a low incidence, but if these patients are usually followed up clinically and also by a lung function test. Now, our chest physicians, their argument is that you've got to, before you start doing a lot of CT scan, you've got to have a treatment. And at the moment, we don't have a treatment for long COVID breathlessness. So they're not doing a lot of CT scans for that because they've got a normal chest X-ray. They've got, maybe fairly normal lung function test, but they've got symptoms and they don't feel that a CT adds very much. I see Monique's got a hand up there.
Okay.
Yeah, if it's possible to comment on that, because we tried to do, well, there actually was a kind of a guideline in the Netherlands once the first wave was over, what we should do to monitor long-term COVID or whatever. So there was some discussion on that. And then we said, okay, maybe we should perform CT on a low threshold basis and follow up, just to get to know what's happening and to learn from it for a lot of other patients. And so what they did is perform CT after 3 months, a low dose CT scan with a high spatial resolution of at least 1 millimeter, but we performed at 0.5 millimeter section thickness, and 1 CT scan after 1 year, just to learn from it. So patients had to sign for that as well. And this was correlated with other parameters such as pulmonary function, but also physical, psychological performance and walking distances, etc. And what we saw is that after 3 months, there were a lot of residual abnormalities with involvement of the pulmonary parenchyma, almost the same involvement in volume of the pulmonary parenchyma as at admission in the hospital. So that did not really change, but density of abnormalities and well, especially density and abnormality of the abnormalities actually decreased. But what we saw is it did not correlate with complaints of the patient. It did correlate with pulmonary function, but not with patient complaints. So after that, CT usage was decreased as actually there's nothing to treat, and complaints were not correlating with imaging. And now all 1 year CT scans are made, and still some patients are not normalized yet, but still it does not seem to correlate well with any treatment decision or whatever. So I don't think that follow-up really helps. It only explains why we see abnormalities in patients, that they might have had COVID-19. And the more severe patients which is in ICU patients, they have more severe persisting abnormalities than patients who, well, only had a mild course of disease. That's our experience.
Some publication about the follow-up of patients with CT scan, and we have some difficulties to compare the studies, because what is the T0 for our start? Is the diagnostic, or the outpatient go out from the hospital, or patient was admitted to ICU or not? Because patient in ICU, they stay 2 months, then the 1 month follow, a patient is very bad. Then I think that the Spanish authors, they proposed to start the follow-up from when the patient leaves the hospital. And then maybe you have to compare this study, because it's very difficult to say at 1 month or 3 months after the diagnosis, because if patient go to the ICU, 3 months after, the CT scan is very bad. One question: how often do you see mediastinal emphysema in COVID? And I can answer to this question because we have observed about 5 or 6 patients, but it's very low, and it's not very, very frequent as situation to have emphysema, mediastinal emphysema in patients with COVID. Is my experience. I don't know if you have another experience than this.
We hardly saw it, and incidence is about 1%. That's what I read in the literature. So that's not much, and I think it also has to do with your PEEP at the ICU, for instance. So yeah.
In fact, the patient I said about who they have emphysema, mediastinal emphysema, it was at admission without ventilation.
Oh, at admission. No, we actually did not
at admission, because in ventilation you have all the problem with ventilation.
With pneumothorax, etc. Yeah.
Okay, I'll look if you have another question. Do you have some comments? One question: what is the slice thickness and HRCT of lungs for COVID-19? I think that Dr. Brink, you have answered that 1 millimeter or 1 millimeters 0.5, it could be acceptable. Then for control. And if you want, you can send more questions, and maybe we can see with the Canon Medical System Europe, we can answer to your question after. Do you have any remark? Any question? Now it's 5 minutes past 8 o'clock. Thank you for everyone. Thank you for speaker for your good presentation, and for public to your question. And it was very helpful and very good for me to moderate this session. Thank you.
Thank you very much. Thank you.
Goodbye.